this evening is I actually have an overview lecture that I want to give, and I will make you guys see my screen in just 1 minute. Okay, so here we go. Can everybody see my screen? Yes, okay, good. So what we're going to do this evening is I'm going to give, whoops, I'm going to give an overview lecture, and what this lecture is about. Over the last couple weeks, you guys have listened to tape lectures talking about the different regulations in long-term care. And one of the things that I've alluded to is that the regulations are changing a little bit, and there's been a lot of big news of it over the last 2 years. But in reality, from my perspective, the regulations really aren't changing much, and that's why I still taught you the old regs. They're just being enforced more. And so, what I thought I'd do is give you an overview of this lecture. I'm also going to touch base a little bit about personal care homes and the regulations that they do, because if you are working in a long-term care pharmacy and you're not the consultant, or even if you are the consultant, you may also work with personal care homes, although they don't follow the normal CMS. So we're going to go through that, and then please feel free. I'll be checking the chat thing here if you have any questions. Okay? So one of the things, if we look at the standard of practice of long-term care, whoops, I didn't mean to move that, is that long-term care is sort of a hybrid between community pharmacy and hospital. And like I said, tonight's lecture is just kind of, we've talked about this in prior ones, but this is just more of a snapshot for you to see that, is that in long-term care facilities where the residents reside, most of the times the pharmacy doesn't reside. But one of the things that a closed door long-term pharmacy, why they usually are the ones that have the contract with the nursing home, is they provide a couple different services. One, they provide specialized packaging, whether it's in unit dose, multi-dose packaging. The other thing is, you saw the regulations that I posted just recently under FTAG 425 and 431. There's special rules of labeling and storing. The other important thing is the pharmacy usually works with them in providing either paper medication administration records, or they're providing them electronic health records, MARS, that they can record, and it's required by law for them to do. This schematic here that I have drawing just kind of goes over all the different things that happen, that whether it's a physician, nurse practitioner, that they will either order a new prescription, request a refill, and that medication will get sent to the pharmacy. That either can get sent electronically right through the MARS system, or a lot of times we still do a faxing type system, which then gets triaged at the pharmacy. The pharmacy then will do what all traditional pharmacies do, that they'll check, against profile, against drug interactions, drug disease interactions, formulary checks. One of the things I talked about earlier in this semester, that nursing homes not only take regular patients who are there to live, but they also take Medicare Part A patients who may be there for a short term. And when they're Medicare Part A patients, those patients get paid, the nursing home gets paid a per diem per day to take care of them under Medicare Part A. And so the nursing home is actually responsible for paying for their medications. And so sometimes the pharmacies will work with the nursing home to create internal formularies, and that's what's happening at the processing point. Specialized packaging, labeling occurs. Most skilled nursing facilities get anywhere from 2 to 3 deliveries per day, usually 7 days a week, and usually if there's an emergency request, that can be delivered within 2 to 4 hours. So most long-term care pharmacies work on a 2-hour mile radius, or work with satellite pharmacies to do that. This is just another overview of what all occurs, from the prescription processing to the dispensing to the administration, to return, reuse, disposal. The reason why I just wanted to go through these initially is that every day a lot of long-term care pharmacies are both the dispensing pharmacy and the consulting pharmacy. There are a few states that have passed laws, state of New Jersey, I believe the state of Tennessee, that the nursing home dispensing pharmacy has to be separate. Almost in these new regs that came out, they were going to actually require that, but at the last moment they decided not to do that. So you could actually, a lot of times consultant pharmacists usually sometimes start at the entry level with a long-term care company and work their way up. And that's one of the reasons why we have this course, is to help build you the skills that this is an opportunity, whether working internally in the long-term care pharmacy or as a consultant, you can do. Now, I mentioned several weeks ago that long-term care pharmacy services are changing a little bit based on the new regulations. And the new regulations basically had two phases. First phase was effective on November 28th of 2016 last year. The second phase is actually going to go into effect of this coming year. The second phase that really affects us as pharmacy is some of the psychotropic laws and some of the documentation law. And so this, has been told that this is one of the very first major revisions. Really, from a pharmacy perspective, it's not a major revision. We had a big major revision in 2006, and that's what I taught you based on. Really, what the big revision is in this new regs is how they're going to be enforced from a surveyor process. And we did talk about the surveyor process last time being taped. And so this is just an overview. We talked about FTAG 424, 425, 431, and FTAG 329 over the last couple of weeks. All those FTAGs and the rules that go along with them still exist. They're just falling under one FTAG, and that's 483.45. If you Google that, you can find the listing of these FTAGs, and like I said, they are available on the CMS website. They're very long, intense, and complex, and so one of the goals of this semester was to try to break those down and show you what goes on in them. What's on in these FTAGs, as I said, is the unnecessary drug perspective, the med-error perspective, where that's probably the two biggest areas that you as a consultant pharmacist will deal with, but also the drug regimen review. One of the responsibilities too that the consultant pharmacist will help oversee is making sure the pharmacy, the dispensing pharmacy, is labeling the drugs properly, the drugs are being stored properly, and that sometimes is the consultant pharmacist's job. Sometimes they have a quality assurance person that works for the long-term care pharmacy, and that may be their job. But you as the consultant pharmacist usually are the representative of that pharmacy, and you kind of oversee that. So let's talk about the different changes that are occurring under the new CMS changes. And these changes really are not directly at the pharmacy, they're at the long-term care facility. And so the facility, some of the things that they're going to have to address is they're going to have to develop, implement, and maintain an effective, comprehensive, data-driven quality assurance and performance improvement program. You've heard me talk in other courses about how we are going more to a value-based healthcare type of system, and nursing homes are slowly going to be paid based upon outcomes and patient satisfaction and quality of life. Another big issue that is being focused on in long-term care is the development of an antibiotic stewardship program. And so this program is being implemented to help nursing homes get antibiotics, because there's a big issue between overuse of antibiotics in nursing homes, and those may be affecting what we're seeing in drug resistance in our hospital settings. So this is an initiative to try to tackle that. The other thing in nursing homes is that they have to develop and implement a baseline care plan for each resident, that this occurs within the first 48 hours of admission. And a lot of times, the reason why I lay these out, these are generalities directed towards the long-term care pharmacy. However, not the long-term care pharmacy, the long-term care facility. However, pharmacy, a lot of times, is a very big component of the long-term care facility, and so your responsibilities may be helping developing those policies and procedures, or making sure that they're upkept and enforced. When it comes to the new regs, some of the things that have been talked about, and you've probably heard me interchangeably, and this gets put in the lingo that we either call it a monthly medication regimen review or a drug regimen review, and it still hasn't changed that this review has to be in a skilled facility. All residents have to be looked at on a monthly basis. One of the things that's really been stressed in this new regs is that the pharmacist needs to review the resident's medical chart. Now, depending upon the facility, that medical chart could be paper. It could also be paperless, and so the pharmacist may be able to review some of the resident's medical chart remotely, electronically, but it has to be reviewed on a monthly basis. During that time, you're going to be doing like you've been taught in any type of patient, and that's what we're going to do next week. Next week, we're going to break you out in groups, and we're going to give you different case scenarios to do. And in those case scenarios, just like that example case I gave a couple weeks ago, is you're going to try to identify, is there any irregularities going on? And as I said earlier, you want to look at, what are those happening? The other thing that has changed that's being enforced is when I consult and when I've consulted in the past, I would every month give a report to the director of nursing. I also, if there was a note to give to the physician of that resident, I would write a note. But the one thing that's new in this is that actually the medical director needs to get this report also. And so that wasn't a new addition in these new regs. The other thing is it's been stated, just like in the prior of FTAG 329, all residents' medication regimen review must be free from unnecessary medications. So, what it necessarily is an unnecessary medication. And when we reviewed FTAG 325, I gave multiple examples. But what you're really looking at from an unnecessary medication standpoint is that does this patient have any drug-related problems? So if you think about, if I have a patient's chart and I go to review it, I'm going to, as a pharmacist, first look at, here's their meds, here's their problem list. I'm going to make sure, does everything have an active indication? The next thing I need to ask myself are two questions. Are these medications, what do I have to evaluate the effectiveness of these medications and the safety of these medications? And if I can answer those two questions, then I start looking at, is this medication, is there an excessive dose to this medication? So think about elderly patients. If I have a patient that has renal problems, are these drugs renally dosed appropriately? If I have a patient that the drug is based on weight, is this dosed appropriately? Are there any medications potentially causing duplicate therapy? Remember our example patient when we did the chat session last time, that the patient was on multiple laxatives. Is the duration of therapy too long? There's the controversy of how long do we treat somebody with PPIs? So looking in and evaluating. Is there appropriate monitoring? And that monitoring can be due to evaluate the effectiveness of the drug, but most of the time the inadequate monitoring is, are we getting good monitoring to make sure nothing bad's happening, the safety of the drug. So for example, somebody's on warfarin, we need to follow, what does the therapeutic guidelines say? We should at least get a monthly INR. If somebody's on a blood pressure drug, how often should we check their blood pressure? So you want to look at, you have to rely on your standards of practice to do that. The other thing is, does the medication have an active indication? And are you identifying any possible ADRs or high-risk potential of ADRs? So nursing home consulting is no different than what you see in any type of practice you do. What will be interesting, and I can say this from years of being a consultant, is that surveyors, when they would survey, they would do a very good job of identifying things such as, are drugs properly labeled, that there's no expired drugs in the med card, are they properly stored properly? They would also look at adherence, and what I mean by that, they would look at the electronic or paper medical administration record, and is that being documented appropriately? If somebody is giving a PRN, are they documenting of the effectiveness of that PRN? So that was always enforced when surveyors would come into the nursing home. What will be interesting in these new regs is they're really putting an impact on surveyors to come in and make sure that they can evaluate from a clinical perspective. So last week I gave a lecture about the quality indicators that nursing homes that have to look at. They have to look at everything from falls to symptoms of depression to weight loss. And if in that lecture I gave examples how pharmacy can impact. One of the things that I strongly suggest for anybody who's a consultant pharmacist is that you want to get that monthly quality indicator report. It is done monthly, it is done quarterly, it is done, and evaluate who flags for any of these quality indicators. And what we want to do as a pharmacist, so say that I get a list of everybody that had a fall in the last month. My job is to evaluate the drug regimen and make sure no drugs are leading to falls. If I get a report of how many patients had significant weight loss, I should look at those patients and evaluate could any drugs be contributing to their weight loss. And if there is, I should identify the problem, work with the attending physician or prescriber, and see what we can do for that. And so there's a reason why I went over those 24 quality indicators last week, because it is, charting in nursing homes is not always perfect, trust me. And next week, I'll give you some examples of that in our case, because you're not going to get all the information. You got to think about what questions do I need to ask? What do I got to look for? But the quality indicator report is another place. Another good place to take a look at is the MDS, the minimum data set. And the minimum data set has to be done within the first couple, least couple days to a week when they're first admitted, and then it gets done on a quarterly basis. And this is a comprehensive assessment looking at the whole patient. It is the basis for the resident's care plan. It is how nursing homes get paid, and it actually extrapolates from those quality indicators and quality measures. So the MDS, and so if there's a change in the MDS, there actually is a physical report that gets reported. And when I would consult, I would look at quality indicators, I would look at MDS, and it would help guide me of what residents that month I needed to focus on maybe a little bit more. I still had to review every chart, but this was tools that helped guide me from that situation. Anybody have any questions so far? No questions? Anybody want to just give me a no, just to make sure everybody's still out there? Okay, good. All right, just testing you. All right. The other thing that I talked about in the prior, talking about, the FTAG, the reviews, medication regimen review, is that there has been put on the responsibility that has always been there. And this one has gone back and forth over the years in changing the rule. But the responsibility of the attending physician is that they need to review what you identify as the consulting pharmacist. And he or she has to provide some type of action. And that action can be that they agree with you and they follow out your recommendation. But if they disagree with you, which they can, because there might be a difference in clinical opinion, maybe there's some data you weren't aware of, that they have to document why no action was taken and what was the rationale to be provided for that. So that when a surveyor would come in, and I can tell you in the past, there are times where I would have physicians who may not look at my note. There would be physicians who may acknowledge my note, but they would never tell me why they disagreed. Sometimes physicians would just say, no thanks, I don't agree. They're not allowed to just say, no thanks, I don't agree. They have to provide their clinical rationale of why that is. The other thing in the past is a lot of times that documentation sometimes was outside of the medical record. It is now required that documentation needs to always be part of the resident's medical record. It might not be directly in that chart, but that has to. This change of response by attending physician is going to be enacted and effective in phase 2 as we enter this month. So some summaries of the medication regimen review response. Pharmacists, here's some options that a consultant pharmacist could do. Pharmacist writes the drug regimen review directly into the medical record. The physician responds directly. The only problem with this is it's difficult to audit, it's difficult to follow. And one of the things that I would do as a consultant, I would review the following month, what were the responses for that. I actually would have the nurses fax those to me at the pharmacy once the physician did respond. Another option is the pharmacist writes the drug regimen review on a separate form. The physician writes the response on the form and writes a separate note on the medical record. The downside of this requires double documentation. The third one is actually what I would do and what I've done in the past. The pharmacist writes the drug reg review on a separate form. A lot of times your consulting software can actually produce this, and so my software would produce this and it would be printed out. It would then actually, give down the bottom a place for the physician to respond to either agree or disagree. And then what would happen, they would then take that response, they would fax it to me that I would have a copy. A copy would actually get filed in the nursing office and the original would be on the chart. And so this is probably the best way to have this, done, and it's the best way to document. And like I said, it's a good way too. What the director of nursing would do in a lot of places that I would work with, they would actually, if I wasn't physically there, follow up with the physicians who did not respond to notes and say, hey, did you see this note? And have them respond. The other thing that gets debated all the time is what is the time frame for a drug regimen response? CMS does not really come up with what that is. Years ago, I had a physician who just didn't sign anything. It wasn't just me. He just didn't sign anything, nursing reports or whatever. And eventually we had to follow the chain of command and have the medical director talk to them. But this physician still did not respond. And eventually the home got cited, and the physician actually pretty much was given an ultimatum that either A, they do better work in responding to documentation, or they were no longer going to be able to see residents there. So, the possibilities, and I'm sorry, something happened in these slides. The spacing is a little bit different here, but let me just go through. So, things could happen. When should a good response happen? One, probably the best is prior to the pharmacist's next monthly review, and that's what I've been told by surveyors, that it should be responded within the next 30 days. All right, more promptly if possible. What really should be deemed acceptable is what you think is urgent. The drug regimen should always be responded to as soon as possible. And what I usually would do is, if it was needed to be urgent, I would actually then call the physician, page the physician, or have nursing do that and see what they think. I would still document what the physician told us and then actually have that summary report so the physician could sign off on it. We still don't have a good ruling of what will be deemed acceptable, but in most cases, it's usually within the next time the pharmacist does the review, but still use your best clinical judgment. If you think it's something acutely that needs to be addressed right away, use all channels of communication to do that. The next big thing that's going to be enforced that has gone through the history of time since the late 80s is pharmacy and psychotropic medications. In the new regs, the definition of psychotropic medication has been changed and expanded, and basically says that any medication that affects the brain's activities associated with mental processes and behavior that include your traditional classes such as antipsychotics, antidepressants, anti-anxiety drugs, and hypnotics. The consulting pharmacist should monitor that psychotropic medication is being used to treat a specific condition that is diagnosed and documented in the resident's clinical record. Where there has been problems in the past is a lot of times, and you're going to learn this next semester when you learn Alzheimer's, is that a lot of times, sometimes psychotropics can be used for behavioral issues. They also can be deemed by CMS as chemical restraints. And so the biggest rule to follow when you're looking at a diagnosis and making sure it's diagnosed properly is true, they could have a true psychosis diagnosis. Most of the time, a good nursing home will consult with a psychiatrist, and so a lot of times the attending physician will ask for a psychiatry consult. The other thing, that if you're using any type of drugs that I mentioned for behavioral issues such as Alzheimer's, the rule should state this: is the behavior a harm to themselves or a harm to somebody else? Harm to themselves or harm to somebody else could be physical harm, such as biting, kicking, scratching. Harm to themselves could also be things such as pulling out an IV line, could be that they're, picking an area of a wound. So I had and I might have said this in one of my prior taping lectures, I had a resident who would, think that their daughter was still 10 years old and she would try to escape every day at 3 o'clock to pick her up at the bus stop. So that psychosis was a harm to themselves. The other thing that's required, and we talked about this in FTAG 329, is that the resident who's receiving the psychotropic should have gradual dose reductions. Nursing and care planning should look at other behavioral interventions that may not require medications. We used to get a patient who would get all upset if somebody would actually bump her wheelchair, and she would start wailing and screaming. But all the nurse had to do was tell her, let's sing a song. And they would sing a simple song, and that resident would start singing, and then all was well. So didn't need a chemical restraint. And so that is one of the care planning that has to happen. And so one of the things that I've strongly found successful is good nursing homes that have a psychotropic team that at least meet once a month to review the residents on psychotropics, getting a physician involved, and having that all that documented and charted does help out. Because the one thing that surveyors are probably going to do, and they have already started to do this, is that we do know that other drugs besides antipsychotics have been used for psychotropic medications. Examples: the use of trazodone for sleep, the use of Depakote for behavioral control, especially such as things such as bipolar. We see other anti-epileptic drugs used for that. And so we need to make sure that those things are being documented. One of the things that still has not changed in the regs is nursing has to document those behaviors, and usually they have to have what's called behavioral monitoring sheets. And you, the pharmacist, needs to work with nursing and the physicians to make sure those are documented appropriately and dose reductions. It's not always easy, but if you have good documentation and showing where you did attempt to try to do dosing decreases, that those nursing homes, regardless if they're on psychotropic meds, usually do well in the survey process. In the phase 2 focus, one of the big focuses is on the use of PRN medications. And the reason why PRN medications, if you think about it, if you're using a drug for PRN purposes, most of the times you have to evaluate, is it really intended for PRN? And are we just using it as PRN because we know the drug has sedation properties and all we're doing is trying to sedate them? And because we're not taking it chronically, maybe there's a greater risk for ADR such as sedation and confusion. So, under the new regs, residents who do not receive a PRN psychotropic medication unless the medication is necessary to treat a diagnosis specific to that condition. So, for example, maybe somebody has really high anxiety, but they're also depressed. We know that it takes multiple weeks for an antidepressant to kick in, so maybe temporarily we start them on a low-dose benzodiazepine, or maybe like something like buspirone to cover them until the antidepressant takes effect. Though buspirone's not a great example because buspirone itself takes 1 to 2 weeks to take effect. So, if PRN orders are used, they should be limited to 14 days. That includes hypnotics also. If an attending physician or prescriber feels it's appropriate for the medication to be longer than 14 days, then there has to be significant rationale documented in the resident's medical record of why the duration of the PRN order must be indicated. PNR orders cannot be renewed unless the attending MD or prescriber evaluates the resident for the appropriateness of the medication after 14 days. So there's going to be stop orders. And the biggest risk with these stop orders and why good communication is, we know that if somebody's taking chronically a drug like a benzodiazepine for 14 days, we run the risk of withdrawal side effects. And so there needs to be a good communication point, especially when we start maybe getting to day 9 or day 10 of what are we going to do. The other thing that falls under the new regs, and pharmacy has always been a part of this, is the requirements of evaluating med errors. And this one is a real new one that pharmacy was not a part of, is making sure vaccinations are being done where patients are eligible. One of the things under skilled nursing facilities is required to maintain a medication error rate below 5% and that the residents are free. Talked about in the prior lectures about doing med passes, and that is the best way to evaluate if nursing homes are having any med errors. There should also be a med error reporting system, and this is something that consulting pharmacy has been involved in for a long time, and they usually provide reports of their med pass evaluations and also documentation of med errors, because the purpose of a med error reporting is to look at where are we doing things wrong and how can we improve those to prevent future errors. The vaccination one's an interesting one, and this probably has evolved a way pharmacists have become more responsible in vaccinations. And so, one of the things we need to make sure that everybody that's eligible for an appropriate vaccination is done, and that should probably be documented somewhere in the pharmacy review, at least on a yearly basis or every couple of months basis. Especially, it should be done within a short period of time of that resident being admitted to the nursing home for the first time. The other thing that the pharmacy is in phase 2 is the pharmacist is part of the facility's infection control committee, and the pharmacist will be a leader in the area of antibiotic stewardship. And you probably have learned about antibiotic stewardship in your infectious disease class. But what can the pharmacy and the consultant pharmacist do in terms of antibiotic stewardship? Obviously, maybe do some drug regimen reviews, some retrospective reviews of what is the current prescribing patterns occurring. A lot of times, nursing homes affiliated with a local hospital will develop antibiograms. So, looking at what are the best drugs to use empirically if we are going to treat an infection. And this requires some antibiotic expertise, working with maybe the clinical pharmacist at the local hospital where most of your nursing home residents are coming from to do that. Providing staff education. Years ago, and I'm probably talking about 15 years ago, I had 2 students on rotation with me, and we were working with a nursing home, and we just did a simple in-service with nurses of what is the different signs and symptoms of a common cold and a bacterial infection. And we talked about how treating symptomatically the cold and not necessarily reaching an antibiotic. Because a lot of times what can happen sometimes is nurses have a lot of control and power. They may call up a physician and says, it's Saturday night. I think Mrs. Jones may have an infection. Do you think we could get a Z-Pack? I find with nursing in-servicing and talking about good prescribing, along with talking to physicians, you can see a lot of good utilization with that. And so pharmacy can play a big role in antibiotic stewardship in those different areas. So that is we're done talking about skilled nursing facilities and the regs, and that kind of just gave an overview. And I know we went into more detail, and next week we're going to apply some of those applications. But does anybody have any questions at all in regards to skilled nursing and consulting pharmacy? Okay. All right. If you have anything you think about between now and next week, feel free to do that. That actually takes the point that I want to talk about, and I'll talk about it more next week. But so, couple things. One, next week we're going to do in-house cases. All right, and we will actually break you out in groups, and you'll then have to do a small little presentation in class based on each case. The other thing is we know that after Thanksgiving we are going to do the MTM. The final thing is the second exam. And the second exam, what I do for the second exam is I actually have it as a take-home exam. And the take-home exam is going to be taking, some of them are direct questions. Some of them are cases where you're going to be applying the regulations that we talked about. So just want to put that on your noggin that I'll talk more about that again next week and also the MTM week. But I just want to let you know that the second exam for this course is actually a take-home exam. And I do give you ample time to get it done before the semester is over. Okay? So The last part I'm going to talk about is I'm going to talk about the regulatory compliance guides for personal care homes. I do have listed on the syllabus about hospice, but we need to update that. Hospice actually does get addressed next semester from Dr. Mahalo, and she does better justice of it than I do. So that will not be tested about hospice. And actually, the take home exam will just really reflect skilled nursing. But here in Pennsylvania and in different states, the regulatory compliance guidelines is that the Department of Public Welfare and is the one who oversees the regulatory compliance of personal care homes. It is not the Department of Health, which skilled nursing facilities are regulated by the State Department of Health and CMS Medicare. In Pennsylvania, we fall under the requirements of the Department of Welfare. And the reason why I want to bring that up is that there's numerous things in that report, but there is no law in Pennsylvania that says that a pharmacist has to review the chart on a monthly basis like a skilled nursing facility. However, pharmacy, most closed door pharmacies do provide for both long term care and personal care homes. Some states have passed laws that pharmacists either have to do a monthly review or a quarterly review of personal care home residents, but here in Pennsylvania, it's not a requirement. You may still have in personal care homes MTM requirements from the health plans, but you don't have to do, there's no drug regimen review. But the things that pharmacy oversees is helping them with administration issues, med error issues, labeling, prescriptions, records, storage, and training, which they still all fall on the home enforcing this, but the pharmacy will help along with that. A medical evaluation under the regs says that a medication regimen needs to be done on the residents at least yearly or when they're newly admitted, and that has to be done actually by a physician. It does not say pharmacy. And so when the physician's doing their overall physical, they'll do that. They also have to, when they do the review, to make sure no medications are contraindicated or medication side effects. Sometimes I've dealt with some personal care homes that have actually hired pharmacists to at least do quarterly reviews, but there's no law that enforces to say the pharmacist has to do that. But some homes actually have incorporated pharmacy to help along with that. Another thing that the physician has to help with is evaluate whether or not, because in personal care homes, we have a lot of residents who have made IADL deficiencies where they can't cook for themselves, manage their checkbook, or manage their meds, but they're in a personal care home because they're more mobile, more cognitive. So some residents may ask to be able to self-administer their own medications, but it's up to the physician to evaluate if that's occurring. I just, in these next couple slides, just published a couple of the different regs. You can read through them word for word. But if a home is going to allow somebody to self-administer, there should be a way that the home evaluates along with the prescriber that this is okay. If they are, the home should still remind and document, in an MAR that the resident did take their meds. If a resident wants to self-administer, and if they're going to keep their meds in their room, they have to be in a locked drawer type of situation that nobody else have access to that. Under medication administration, a prescription medication that is not self-administered by a resident shall be administered by one of the following. So who is allowed to administer a med to a personal care home resident? It can be a licensed physician, dentist, nurse practitioner. It can be a graduate of an improved nursing program. A student nurse can do this under direct supervision. And here in Pennsylvania, a staff person who has completed a medication administration training program that is outlined by the state. This state program actually can be trained internally at the personal care home, but they are trained on how to give everything from oral medications to topical to eye, nose. The only requirement of a staff person is that they have a criminal background check and they have a high school diploma. So a lot of times personal care homes may have help people that are administering medications that are not a healthcare professional, but undergone a medication administration training record. Sometimes some pharmacy companies do get certified with the state to help administer this training program, and so that might be something, depending upon what company you work for, you may be part of. Medication administration activities, if it is a, it doesn't matter if it is a nurse or it's a lay person who has a medication administration training, is a couple things they have to do. They have to use the 7 steps of medication administration. Identify the correct residents. How we do that? A lot of times we do that with barcoding, asking the residents their name. A lot of times MARs may have pictures of the residents. They can only give medications if there's an active prescriber's order. They can only do anything such as measuring vital signs unless there's an active order. They remove the medication from the original container. They crush or split the medication as ordered by the prescriber. They place it in a medication cup and hand it to the resident, and place the medication in the resident's hand, for that. And then once they administer that, they have to make sure that it's completely documented. I know those are simple things. We all know that. But that's one thing we do even in the skilled nursing facility. We evaluate the medication pass. As we know, certain medications can't be crushed. As we know, certain medications can't be split. As we know that certain medications have to remain in the original manufacturer container. So all those things have to be evaluated. In terms of storage, all right, prescription medications, OTC medications have to be kept in either label containers, and they cannot be removed, whether it's a bubble pack or it's unit dose or the container, more than 2 hours in advance of a scheduled administration. The other thing is, they can also give injectables if they're trained appropriately. Labeling of medications is just like in the community pharmacy. It has to have the resident's name, the name of the medication, the date that the prescription was issued, the exact dosage and instructions. Just like skilled nursing facilities, you have to put the exact route by mouth, bi-rectally, via inhaler. You have to give that, and also the name and the title of the prescriber. The other thing that's required under a personal care home is they have to document, and keep track of controlled substances. Most pharmacies will help them do that. Most of the time they're bubble packed. They'll provide documentation to do med counts, to evaluate that. Some personal care homes will do controlled med counts per shift, and they have to be stored and locked. Most med carts provide an additional double key lock area for controlled medications, and only certain people are allowed access to that key. The other thing too is some type of medication record shall be kept that each resident that they got their medications, and you can read through, but it's all the traditional things that we would do in a medication administration record. So hopefully tonight that kind of just gave a good summary of what we talked about, and I think it's always nice to give a live versus a tape session. I did post, and I apologize, the prior tape lectures the last 2 weeks. I just had the tape lecture, not the PowerPoints. The PowerPoints are now up on Blackboard for you to review. I will be posting this too after we're done, hopefully recorded successfully, for anybody that go back and review. Any questions? Okay, well, I appreciate everybody coming to listen to this live, and get to see you the next two classes live. We'll start at 6 o'clock at the school, like we did. And I will see you next week. All right, everybody, have a good night.